In this presentation, we will be discussing thyroid disorders. My name is Dr. Lynn Shea, and I am a family nurse practitioner in a rural health center in Pennsylvania that provides full-scope family care to patients of all ages. With a base in women's health through an additional certification in midwifery, I also treat many patients with endocrinological disorders, including diabetes and thyroid dysfunction. Today we are going to be discussing thyroid disease. You will be routinely seeing patients in primary care with a variety of complaints that warrant a thyroid evaluation. So it's important to have a good understanding of thyroid diseases and how to examine the thyroid gland. Let's start by reviewing the thyroid anatomy and then discuss 4 common thyroid disorders: hypo and hyperthyroidism, goiter, and thyroid nodules. The thyroid gland is a butterfly-shaped organ located just below the cricoid cartilage in the neck and surrounds the trachea. The gland releases hormones that control metabolism, and its hormones regulate vital body functions including, but not limited to, the following: breathing, heart rate, central and peripheral nervous systems, body weight, muscle strength, menstrual cycles, body temperature, and cholesterol levels. As you should recall from pathophysiology, the thyroid uses iodine from foods that you eat to produce 2 hormones, T3 and T4. The hypothalamus and pituitary gland in the brain regulate the production of T3 and T4 by means of a negative feedback system. The communicator from the brain to the thyroid hormones is TRH and TSH, thyroid-releasing hormone and thyroid-stimulating hormone. TRH from the hypothalamus signals TSH in the pituitary to tell the thyroid to produce more or less hormone. When T3 and T4 levels are high, the pituitary signals the thyroid to produce less hormone by decreasing TSH. The opposite is true for when the thyroid produces too little hormone. The pituitary increases TSH to signal the thyroid to make more. Although examination of the thyroid gland can prove to be challenging, success can be achieved by using a systemic approach and a good technique. A goiter simply refers to an abnormal enlargement of the thyroid gland. The presence of a goiter should signal the provider to investigate for thyroid abnormalities. There are several etiologies for goiter that we will discuss today: Hashimoto's thyroiditis, Graves' disease, and thyroid nodules. Worldwide, the most common cause of goiter is iodine deficiency due to diet deficiency. The thyroid uses iodine from the blood to produce T3 and T4, so if there is insufficient iodine, the thyroid enlarges, but thyroid hormone remains low. Although goiter is not as prevalent in the United States anymore, the incidence of goiter remains high in populations where iron deficiency is common. There are several labs that are used to determine thyroid function that include the following: thyroid-stimulating hormone, TSH, is a pituitary messenger to thyroid to increase or decrease thyroid hormone production. Free T4, circulating unbound thyroid hormone produced by the thyroid, replaced by levothyroxine medication, useful for the diagnosis of hypothyroidism, both overt and subclinical. Total T3, circulating unbound thyroid hormone that has been converted from T4, useful for the diagnosis of hyperthyroidism. Thyroid peroxidase antibodies, useful in detecting autoimmune thyroiditis such as Graves' or Hashimoto's. Thyroglobulin antibodies, useful in confirming or differentiating between autoimmune thyroiditis types such as Graves' or Hashimoto's. Do we screen for thyroid disorders? There are differing opinions on whether to screen for thyroid disorders in asymptomatic adults. Although there is no consensus about population screening in healthy individuals, there is evidence to support screening in the following at-risk populations, including those with autoimmune disorders, pernicious anemia, first-degree relative with autoimmune thyroid disease, history of neck radiation, history of prior thyroid surgery or dysfunction, abnormal thyroid examination, and psychiatric disorders. Additional diagnoses that support thyroid screening are listed in Table 9 of the ATA-AACE Clinical Practice Guidelines. Hypothyroidism is a condition where too little thyroid hormone is produced. There are 3 forms of hypothyroidism. Number 1, overt hypothyroidism. TSH above 10 and FT4 is decreased. This makes sense due to the normal physiology of the hypothalamus-pituitary-thyroid axis. Too little hormone is being produced, and the pituitary is attempting to get the thyroid to produce more. Low, free T4, and high TSH. Subclinical hypothyroidism. TSH levels are above normal, but the free T4 is within range. Frequently, patients with subclinical hypothyroidism exhibit some symptoms, whereas others may not. Autoimmune hypothyroidism, Hashimoto's. The body produces antibodies to attack the thyroid gland, which results in hypothyroidism. Autoimmune thyroiditis can be detected by antibody markers in the blood, TPO and TPG antibodies. There are varying opinions on whether subclinical hypothyroidism should be treated, but ultimately it is the presentation of the patient that will determine whether treatment will be beneficial. If the patient is symptomatic, then treatment is warranted. In overt hypothyroidism, both TSH and free T4 will be abnormal. TSH will be high and free T4 will be low. Common history and clinical findings include the following. Please see the chart. Differential diagnosis will depend on the specific complaint of the patient. Treatment with thyroid replacement hormone levothyroxine is the treatment of choice. Desiccated thyroid preparations such as Armour can be used, but generally speaking, levothyroxine is the approved agent. There are 2 ways to dose levothyroxine, brand Synthroid. You can dose by ideal weight at 1.6 micrograms per kilogram or follow a dosing schedule dependent on the level of TSH. It is important to add that if you choose to medicate according to weight, you should dose by ideal weight in order to avoid over-medicating the patient. The second method is to select a dose based on TSH range. TSH 4 to 8, 25 micrograms. TSH 8 to 12, 50 micrograms. TSH greater than 12, 75 micrograms. Medication should be titrated to every 6 to 8 weeks until target of 0.45 to 4.12 is achieved. Once target is achieved, retest every 6 months until stability is confirmed, and then consider testing yearly if appropriate. Special medication instructions and anticipatory guidance for patients taking levothyroxine. Thyroid medication should be taken with water 60 minutes before ingestion of any other substances and/or eating and drinking. Many medications and substances interfere with thyroid medication, and therefore timing is important. If too much medication is ingested, patients may develop tachycardia, nervousness, irritability, and become manic. Titration of medications in patients over 65 should be done carefully, slowly, and with consideration to comorbidities such as AFib and cardiac disease. In pregnancy, the target is 0.45 to 2.5 in the first trimester, under 3 in the second trimester, and under 3.5 in the third trimester. In pregnancy, TSH testing should be completed every 4 weeks in the first half of gestation, then once between weeks 26 to 32. Postpartum TSH should be checked within the first month postpartum, as postpartum thyroiditis is common, and previously diagnosed patients with hypothyroidism could have lactation difficulties if not adjusted properly. There are times when consultation with an endocrinologist can be helpful. This includes patients with labile TSH where medication titration is difficult. Patients with infertility and seeking pregnancy with hypo or hyperthyroidism should be referred. Patients that have established cardiac disease would benefit from consultation. Infants and children should always be managed by a pediatric endocrinologist. Hyperthyroidism is characterized by the excessive secretion and synthesis of one of both of the thyroid hormones, T3 and T4. Hyperthyroidism can be classified into subclinical or overt. Subclinical. This is where the TSH is low or undetectable, but the free T4 and thyroid antibodies are normal. It is prudent to monitor patients regarding the situation if they are over 65, as the likelihood that conversion to overt hyperthyroidism can occur. Asymptomatic patients under 65 with a TSH of less than 0.1 or between 0.1 and 0.4 should also be monitored for conversion. Overt. Clear evidence that a low undetectable TSH with high levels of free T4 and/or T3 exist. Common forms of hyperthyroid include the following. Graves' disease. This is an autoimmune disorder characterized by agonist antibodies that cause an overproduction of thyroid hormone. Graves' disease accounts for 80 to 90% of hyperthyroid cases. Subacute thyroiditis. This is glandular inflammation and follicular cell destruction, frequently found after a viral infection. Toxic multinodular goiter. This is a complication of chronic inactive nodule goiter, typically due to iodine deficiency. 4. Toxic adenoma. The clinical presentation of hyperthyroidism depends on the duration, the amount of excessive thyroid hormone secreted, and the organ system affected. So like hypothyroidism, the differential diagnosis will depend upon the presenting complaint. There are 3 approaches to hyperthyroidism. Radioactive iodine. This essentially destroys thyroid tissue and creates hypothyroidism in the patient. It is contraindicated in pregnancy, lactation, or in women seeking pregnancy within the next 6 months. Antithyroid drugs. There are 2 main drugs used here in the United States. Before initiating these medications, it is important to obtain a CBC and LFTs because they can cause rashes, elevated liver function tests, agranulocytosis, and hepatotoxicity. MMI. Usually started at 10 milligrams daily unless free T4 levels are more than twice normal. PTU. Starting doses of 50 to 150 milligrams 3 times daily. Beta blockers can be used as an adjunct for patients with symptomatic tachycardia over 90 beats per minute and/or with cardiovascular disease. Thyroidectomy. This is a surgical procedure that is a definitive cure and used primarily in individuals who have failed antithyroid drugs and/or who are not candidates for antithyroid drugs. Recommendations for the type of therapy related to a specific condition can be found in Table 5 of the ATA guidelines. Most cases of hyperthyroidism will need at least 1 consultation with an endocrinologist. Hyperthyroidism is a situation where the course of progression is often hyperthyroidism initially, and then as the thyroid burns out, it becomes hypothyroid. Pregnant or lactating women or women seeking pregnancy within the next 6 months should be managed by an endocrinologist. Finally, let's discuss thyroid nodules. Patients with large thyroid nodules will often present with symptoms of a lump on their neck, difficulty swallowing, having a choking sensation with eating and drinking, or voice changes. If a nodule is palpated, checking a TSH and thyroid ultrasound is indicated. Nodules greater than 1 centimeter should be referred to an ENT or surgical oncologist for fine needle aspiration to differentiate between a benign from a cancerous lesion. Nodules are more likely to be cancerous in males, patients with Graves' disease, children, adolescents under the age of 20, or patients over the age of 70.